Okay. You guys see that okay? Here's our first electrocardiogram. So this is ECG cases, and we're going to try and puzzle through those together, get the panel's thoughts on whether these are normal, abnormal, pass, fail, further testing, etc. Dr. Estes may say we shouldn't have done these, or whoever shouldn't have done these ECGs, but I'm sure he's faced with seeing them because they're getting done. There are pilots, and I think that's a good takeaway that we need further data. So this is a 17-year-old basketball player who wants to move on and play at the next level. What do you think about this electrocardiogram? Is there a volunteer on the panel?
As I think what you're going to see with the group of experts is exactly what we're dealing with. So I'm going to say nothing.
Eugene.
Jim, I knew you were going to call on me.
Wait, I have a suggestion. Should the least expert in this go first? In other words, I'm not an electrophysiologist. I run preventive cardiology at Hartford Hospital, okay?
Don't believe it for a second, okay? Yeah.
But you can go first if you want. I think it's different when a couple of electrophysiologists look at it.
Volunteer.
Paul, you want to go first?
Yeah, I'll go first. So
Paul's usually ahead of the pack on everything. So
I'll defer to Dr. Tom. I'll go second. How's that?
So I'm not an electrophysiologist, so I think I'm the sort of person that would be stuck looking at this. And so, first of all, I always never can separate the EKG from the athlete. I never can do that. I always like to know what's going on with this person. So there are a couple, at a quick look, there's nothing that bothers me a lot. The ST segment elevation is okay and all that sort of stuff. The stuff that bothers me is the look of the PR segment in leads 3 in AVF. And I just wonder, and I can't make, I just want to make sure I'm not missing a delta wave or something. So if this kid if it was asymptomatic and I was just running through them, I would probably continue to run through them. On the other hand, if this kid had some sort of complaints, I would be a little bit more concerned. So it's very hard. That's one of the problems I have with screening, is that for me, looking at these things, I can never kind of separate the EKG from the corpus. That's Latin for body for you. No.
So just to segue with the last thing Dr. Thompson mentioned, that often these ECGs come to me in maybe 20 at a time in PDF form, just like this, and I don't have much information other than 17-year-old freshman basketball player or something like that. So at first glance, you want to look at the ECG as maybe like a radiologist, call what you see, but then sometimes you'll see things, and then I think, as Dr. Idriss mentioned, you want to step into evaluation. But when I first look at this, it looks like sinus rhythm. The heart rate's not too slow, but I see quickly that there's a J-point elevation in multiple leads, which I probably would call early repole. The voltage does seem a little high, but for a 17-year-old, it's probably okay. There are Q waves in V5 and V6, which, because the voltage is high, maybe by itself is not concerning, but they jump out at me too. I don't see Q waves in 1 and L that jump out to me as much as V5, V6, but they're there. There's a prominent T wave inversion in V1, but it looks like the T wave in V1 is upright in V2, so I'm not too worried about that T wave. But while possibly normal for an athlete, doesn't look quite normal, and so I would admit this type of ECG I would probably ask for more information. That's how I'd approach it.
All right, Dr. Idriss, more information, more testing?
I would just ask the team doc so presuming this is a screening ECG, I would just confirm if there's any history, symptoms.
Asymptomatic.
Yeah.
So that's a lot of history. So presumably we would be getting this without even the fact that this is a basketball player, and that's to me irrelevant. So At best, I would be getting that this is a 17-year-old. If it was just coming across my desk and I was reading it, for example, out of wait med to ER, I may have a location. And the fact that it may say it was in ER would make me start to think and suspect that he had chest pain or something made him show up in the ER, which raises my suspicion flag a little bit. But if I had no suspicion flag and I was just looking at this, I would say this is I'm not worried about the PR segment. I don't think it's pre-excited. I think there's normal, relatively normal intervals in repolarization, appearance with early repol. I would blink at the left-sided forces and left-sided voltages, which would make me concerned or suspect potentially some hypertrophy. However, even though it meets voltage criteria based on age, at least solely for 95th percentiles, I would start taking into account how I'm reading it. If I were looking at this in clinic and I knew the patient, I knew what I was doing, I would read this as early repol normal, and I wouldn't do anything else if there were no symptoms. If I were reading this in isolation from an ER visit or anything, I don't know what this child, I don't know who evaluated him, I don't know why he showed up. I would probably put a possible LVH on this one solely to flag it a little bit, or a borderline ECG solely to get sort of a next step so somebody could get more information. But that's how I read it.
So I'll agree with everyone's thoughts on what everyone already said. I agree that PR intervals doesn't look to me like it's pre-excited. I think what I just wanted to comment upon was the use of the word early repolarization, because I think it's such a nebulous term, and I think we would all probably, just because of convention, call this early repolarization. I'm not sure the definition of what we would call early repolarization is well known. So I'll just take a moment and just say this looks like a very benign based on some of the data that's been published in Europe. There's an upsloping, very, very rapidly onset from the J point elevation to a upsloping ST segment that occurs within 100 milliseconds of that J point. And that, what we've seen in population data, seems to be the more benign variant of early repolarization. The word, and why I sort of hesitate to use the word early repolarization, is because there is literature on early repolarization syndrome, which is associated with idiopathic sudden death. And so I think it's, when we use the word early repolarization, we need to define either benign early repolarization or malignant early repolarization, or redefine what the malignant type is and change the name of that. But I think this, because of the rapid upsloping and the, I think rapid upsloping from the J point deflection, is that sort of defines that benign variant, especially in the setting of a 17-year-old with a lot of sort of high voltage on these QRS complexes.
Any further comments, Dr. Estes?
I don't know whether this is normal or abnormal. If this is a 17-year-old basketball player with this EKG and he's asymptomatic and he's black, it is highly probable it's within the spectrum of normal. If it's a 17-year-old basketball player who is not black, who's had syncope, it's almost certainly abnormal. So the context is always important, and over the years, Paul's taught me to really ask, why the EKG was done, what are the symptoms. But the fact is, in the real world, pediatric electrophysiologists, adult electrophysiologists, and even cardiologists, Paul, who aren't experts, are going to be given this EKG, and you've got to say, normal or abnormal. What are you going to say?
I would say normal.
Normal, Paul.
So look, so let me say, I got a problem with these PR segments. I don't like to see, I like to see a PR segment like it looks in one. I don't like to see a PR segment like it looks 2, 3, and AVF. So I'm saying, I would say it's abnormal.
Abnormal?
Yeah.
Eugene?
I'm going to say normal.
Normal?
Yeah, I would say normal. So.
Okay, so here we have 5 experienced cardiologists, electrophysiologists, who can't agree on a single EKG, okay? So this makes the point, I think, that there's an overlap of normal and abnormal. Could be normal, could be abnormal. And if you look at those Venn diagrams of overlap of normal versus abnormal, this would fall right into the middle of an indeterminate zone in which the athlete would clearly need further evaluation. and it's going to be an echo. No question about it. In the real world, in Italy, no question about it. Meets voltage criteria, 2 millimeters of ST segment elevation, PR short. In Italy, this person's going to have an echo. They're going to have a 2-step stress test, and they're going to be further evaluated. So that's the way things work in Italy. They've got the resources, and it's paid for. And guess what? The physicians are liable if they get it wrong. So of course they do additional testing. And that's the way that program works. In the United States, I really doubt in the real world, not on a panel, whether this EKG came across someone's desk, a 17-year-old basketball player, they'd be willing to say normal. Because this could be an early repolarization syndrome. Inferior 2 millimeter ST segment, admittedly upstroking, and lateral. This kid's had syncope and he's a white kid. It's probably early repol. So
But he's asymptomatic.
He's asymptomatic?
Yeah.
yeah, so are the hypertropes before they drop dead.
But
I'm saying this is what we're dealing with. It's
The early
extremely
repolarization
difficult, even
is-
for experts, to determine normal from abnormal. And I would, if I saw a patient like this, want a lot more information. I'd have to get a good history, a history that I took, being mindful that that hypertroph that had been to 3 other hospital halls. Nobody asked about the conditions of the syncope. But I think Bill's got a comment too. So I don't know, but here we are. It's a single
Can you go to
EKG,
the
a single
microphone,
athlete.
Please.
Yeah, a single EKG, a single athlete. And I struggle with it. I don't know whether this is normal or abnormal. And I consider myself to be pretty knowledgeable at reading EKGs.
First of all, we're talking semantics. There isn't a panel of stuff there that would call this a normal EKG.
Agreed,
You would never read that out as a normal,
agreed.
right? What you're trying to decide is it normal physiology, right?
There's not enough information to decide that here.
Right?
Yeah.
Exactly. You don't have a history, you don't have a physical exam. My question is, does a physical exam help you?
No, useless.
History
Unless
and
there's
physical are
obstructive
normal.
hypertrophic cardiomyopathy or aortic stenosis. Okay? Almost useless. So Jim, what do you think?
Well,
What do you think?
Well, I took off on the slide that it was a Duke basketball player because I didn't want Eugene to automatically disqualify him. And I think we talked about the Seattle criteria. So any thoughts on here as to where this meets or doesn't meet things?
I think he would have passed.
So isolated voltage criteria and early repolarization by these criteria are, not reading ECGs normal, but in athletes being screened who are presumed to be asymptomatic that wouldn't have gotten that far, that would pass, wouldn't it, panel?
I think so.
Would probably pass the Seattle criteria.
Okay.
I don't know about the refined, because I can't remember if early repol is in one of those borderlines with 2 findings.
Yeah, the early repol, 2 millimeters in lead 2, and the inferior and lateral, could indicate that there is a true early repol syndrome.
But an asymptomatic that is has an extraordinarily low predictive value for an event.
Agreed fully.
Especially it depends on the race. If this is a young black man, this is a very, very common pattern with an upsloping
Oh, yeah.
segment.
So
like that.
white or
So
black
that would be-
basketball player?
African American.
African American.
And large.
So more and more likely going to be normal. But
And I'll give you additional information. We didn't recommend any further testing, but I know that since all NBA players have had echoes and stress tests, he must have passed.
so a Duke player, who read the EKG?
I did.
You did. And you said, you're cool, go ahead.
I said that it was not monitored by Seattle or ESC criteria, but it needed to be bumped up the chain.
So why was the EKG done?
All athletes are screened at Duke.
Okay.
And you cleared him?
Yeah.
So the question is, you use the ESC criteria, use criteria
Use the microphone, please.
to screen. Okay, you're saying that based on criteria, but
But you had no
You're-
syncope
you're
and you had the
physician.
black athlete.
right,
Yeah.
you're looking at evaluation, right? Not just to use criteria to fly through. So again, screening with a criterion, and we're sitting here looking at these criterions, is green light, red light, period. It's not there's early repole, it's not anything else. So did you let him go or not?
Yeah, so that's a great question. We gave, like I said, our role in setting.
And so use them.
There's a sports cardiology fellow or cardiologist that kind of participates in the first brief read of these ECGs. So we see them typically within 30 to 60 minutes, and they're overread within 24 hours to kind of make up a game plan if someone needed further evaluation. So this met the, we followed the criteria. We just thought it was very impressive LVH. I probably looked at maybe 300 or 400 athlete-specific ECGs during this process, and it was one of the more interesting looking things. I actually was impressed with that V1, very impressive T-wave inversion, although V1 is free, but that was very impressive, the most impressive one I've ever seen, and then the no T-wave inversion through the rest of the precordium. So again, no criteria. So again, at that level, I'm not allowed to make that decision. I think I would have given it a green light. I'm a board certified cardiologist outside of Duke now, but a fellow here, so I would give him the green light actually.
So, but here's the point. Okay, in Italy, this is just the kind of attention these get. These are really, really expert people, like yourself and like Jim, and they have the context of the screening. They've got history, and they've got physical findings, and they've got the EKG. Like in Italy, it's being done through a center of expertise where they have regional centers. This is completely infeasible in the United States of America. Do you want to be looking at hundreds or thousands of EKGs every year without seeing the athlete or having that background information? Can we delegate this to family practitioners, to interns, to pediatricians, general pediatricians who dose it? So how do you address this very practical problem of interpretation of EKGs when you've got 8 cardiologists here debating normalcy of a single EKG? This is what we're dealing with. This is why the healthcare system in the United States is not geared to this. These sports cardiologists are paid to do nothing but sports cardiology, and they are really very good at it. So the infrastructure and the range of normal with a heterogeneous patient population gives me great pause. I'm very willing to look at the evidence to show that it works, but in these selected ones, like Duke and University of Virginia and the MGH people have published it as well, it shows you can reproduce some of the findings, but the sensitivity and specificity are nowhere near what we need for it to be broadly available.
I'll just add to that in terms of the idea of normal or not. I don't think, especially since I know who the patient was, but I don't know if any of us have enough experience to say what does a 6'9", 8, 10, 7'3", 4 person that's 200 to 300 pounds. What is that supposed to look like? Because how many of those people exist in the world, and how much experience do we have actually either longitudinally following them or even retrospectively looking at what develops with their EKG or their heart or their size or so forth, and where the EKG leads are supposed to even go on someone with a chest that's probably 3 times the size of my chest. And so I agree. I think I said normal because of thinking that was normal in the setting of an athlete and pre-screening. So I think we do need to redefine what normal really is in that population.
Would you have made the same interpretation if Duke didn't have an AED program at the
No, I think that's a good point. And to do ECGs on everyone, you've got to, I think, either accept the premise that these normal variants based on the Seattle or ESC criteria need to be passed, or else you're going to be doing a lot of testing on a lot of athletes. So I won't call them patients because they're not yet patients. So I think that's a great thing to emphasize, the AEDs as a safety net, because we can't do an MRI on every Duke student or UNC student or Tufts student. Well, those are all great issues. Let's move on to the second electrocardiogram we're confronting. Is this one that you had seen, Al?
This is another one that came from the Duke screening.
So asymptomatic athlete undergoing electrocardiographic screening. Is the panel going to pass this? Dr. Idriss, you're shaking your head in some direction.
I would not pass
Why?
because there's T-wave inversions that extend out to V4 laterally. I would want more investigation.
Any concurrence or disagreement on the panel?
I would agree that the T-wave inversion after V4 is worrisome in a female black athlete within the spectrum of normal for a male black athlete. But we don't have a lot of data on T-wave inversions all the way up to V4, so I'd be concerned.
The T-wave version also concerned me. There is emerging literature mainly out of UK about anterior separation, which are low elevated V3. T-wave versions up to V4 could be acceptable in African American athlete, but I think a lot of people are, I'm generalizing, are uncomfortable with that because there's just not a ton of data. And I would also, based on this ECG alone, do further evaluation. So.
Yeah, it's really interesting. If you tell me that all of these are screened athletes, then I'm very relaxed about most of the abnormalities. So I agree that it's unusual to have a T-wave inversion all the way out to the V4. And I understand that that's the criteria to start looking for right ventricular cardiomyopathy. The fact that this is an athlete being screened and all that sort of stuff, I'm much more relaxed than I passed most all of them. And I mean that even for the prior one. If I'd known that that was just a kid being screened and not some kid that had palpitations, I would have said, forget it. Because remember, the ability to be a high-performance athlete is a very good indication that you've got nothing wrong with you. So even though I say this is abnormal, I probably would not, be doing a lot of stuff. Could be wrong, but I probably would if she raised it.
Yeah, so I'll comment on this. I agree that the thing that jumped out at me was the T-wave inversions. I think certainly we worry about ARBC. Again, the criteria are used to help guide you, but not absolutes. And I think this would actually probably fit the Seattle criteria as well with T-wave inversions in the black athlete going out to V4 with upright T-waves and V5 and 6. So it would actually fall within the realm of potentially a normal athlete ECG. I think when you look at it, and when I look at it, I try to think, okay, is there evidence or any other evidence of RV abnormalities or depolarization changes that fit? And if you look at the literature and some of the more sensitive ECG findings for ARBC, you're looking at things like the nadir of the S wave to the terminal and the QRS. Those delays that really show that there's a delay in conduction through the RV, you don't see that at all. It's a really sharp, very, very narrow QRS. And Eugene brought it up with the slight ST elevation as well too, which also goes more along probably that those T waves, those two patterns go together in more normal. If this was an ARBC person with significant T wave abnormalities, it's not that they have to have a terminal delay in depolarization, but that is likely the more sensitive, even more sensitive than T wave inversions. And so I would say there is a little bit of contradiction here. And then if you add it to the pre-procedure screening in a healthy athlete that's African American and has no other symptoms, I would probably say this would fall also into the realm of being a normal athlete ECG. But again, whether does that brings up this whole thing, did you get an echo or not?
Do you want to comment on these T-wave inversion, anyone? Abnormal criteria?
I think the updated version, which is circulating in journals, I'm told, is going to allow up to V4 in the anterior corner leads within normal. This is going to be a slight change. And so I'll mention there was I think a paper from the Crowd group last year in the Heart Journal that said there's a little bit of elevation of the J point in association with T wave. That is a little bit more reassuring. But again, that was a unique feature.
So much of this data is based on male black athletes. I think there's much less data in females, and it really gives me caution to kind of push this off as being normal. And beyond that, I know Jim well enough to know that there's going to be some interesting twist here. But you can see again, I mean, amongst experts, disagreement, because the data is not so clear, and it might be normal, it might be abnormal. There's potential for overlap. And in that setting, in the healthcare delivery system in the United States, things are strongly incented towards getting additional information. It's not uncommon to see a patient like this getting an echo for ARVD and having an athlete's heart. And with the slight enlargement of the right ventricle that's commonly seen in athletes, it's MRI as well. So I don't know is my answer, whether it's normal or abnormal.
So I'm confused here. There are people saying that this is not, that this passes the algorithm? If you go back and slide.
So you think it's abnormal?
Yeah.
I think it's probably abnormal.
I would, I tell you, I'd pass along on screen. Let me say one other thing that's, we talk about the Seattle criteria and all that other stuff, but the actual thing that reads the EKGs in the United States is the computer in Marquette's EKG machine. And I'm always saying to the fellows, I think they think it's Flutter. I say, what did the machine say? And the machine says, the machine is awfully good.
So this, the last point there is the T-wave inversion up to V4 is okay, as Eugene pointed out in the setting of the J-point elevation. And as I think Dr. Estes pointed out, predominantly that's been seen in male African-American athletes.
You go back to the ECG.
To the ECG?
Yeah, my experience has been it's unusual in female black athletes. That's my experience. So I would be reluctant to write this off. Would want obviously history, physical, and I think here that I would probably err on the side of making sure we're not missing ARVD.
Just to give you so she did get an echo, and the echo was normal. But let me ask you, because even at our institution, we have a little bit difficulty getting ARVC protocol echoes because they're different. You don't usually measure and do dimensions of the LV outflow tract. You don't do volume analysis of the RV outflow tract, or the volume analysis of the RV and so forth. So would you be okay with just an echo? And the echo came back and was a routine. It was sent to the echo lab as, hey, just follow up on this echo. The echo came back normal, and I looked at the echo, and not all the views are there, but the dimensions were pretty normal. Everything looked pretty normal. Are you going to MRI her?
So let me just go back to the point. So this was read by somebody here, and an echo was recommended. Okay, so this is Duke. This is a world-class institution with world-class people, and they're not willing to say this is normal. So in the real world, you can imagine where this is going. This is going to be an echo most of the time. And because the echo sensitivity and specificity for ARVD is not good, what's next? Okay, Jim, did you read this one too? Did you? No.
This wasn't mine, was this?
Yeah, they sent it to me. I don't know if I was
Let's follow up on this, Dr. Corn.
So I read this EKG in the clinic and in talking to the patient. We decided that we would order the echo because we were worried about the T-wave conversions, and we sort of made the decision at the time with the training staff there. When we were screening these EKGs, at least, there's sort of three different options. One is to just give it the green light and let them continue training. The second is to sort of put a temporary hold on things, get an echo, and the third is to plan on getting an echo, but not stop their training while we're waiting for that. And for this person, she had no symptoms in the past, and we said that we could just order an echo, that she didn't have to stop her training, and the echo ended up being normal. And we didn't pursue any further testing, although, as Dr. Sun said, they didn't get all the ARVC views of the RV.
So the thing is, though, okay. So the one thing is that this is a, just as Dr. Estes said, this is a Duke athlete at Duke. I emphasize Duke. Okay. That you said there was concern for ARVC. ARVC is not diagnosed by echo alone. all right, you have to go through the criteria and decide what other information you're going to get, including signal average ECG, including Holter, although SAECG is a weak link. And echo is not a good finder for RBC. Maybe you'll see some RV dilatation depending on views, maybe not. So if you had the decision at Duke, with Duke and all of your availability, that you were thinking RBC, why didn't you do an MRI?
So I think that
At world-class cardiac MRI mecca.
Well, there is some data that the electrical abnormalities usually precede the structural abnormalities. So
Yeah,
you could maybe get a signal average, maybe Holter, look for PVCs. This could be other approaches. And you know, if we're out evaluating a patient for the diagnosis of ARVC, that's not just out of the blue. That's because they came to us for a reason, or they have a family member with the diagnosis. So there's a different level of suspicion and probability a priori. So the question is, does this ECG alone merit the full workup, MRI, biopsy, signal average ECG, Holter, treadmill, everything? And
I think
I don't know there's a right answer there.
yeah, especially in the setting of some literature that suggests that this may be a normal finding in Black athletes. I mean, remember, this is an athlete, and this is a routine screening ECG. So, I mean, I think it's a great point. Once you go down that road, are you obligated to actually do the full evaluation? Because a echo is probably just checking a box, but not enough to make you. So I'll just tell you, get a diagnosis. The way I would see this in the more common scenario is, this is a 20-year-old coming back from college who's not an athlete, who doesn't go to Duke, who for some reason got an ECG because she went to the ER for something else, and the machine was just almost always wrong. That is abnormal. And then they end up on my door. All right. And I would have looked at this, I would have gotten history, physical, which, you know, as we talked about, extensive family history. I probably would have echoed based on this, and if nothing else, I would have let her go. So that's kind of how I would have.
So if the history and everything is okay, you settle for the echo, even if it's imperfect.
Yeah, because I wouldn't be
sensitive.
based on this. I wouldn't be in my face about ARVC unless all of a sudden we had family members who had dropped dead and unknown, and that other stuff that throws in.
Okay, I think we've brought out some good points there. Was this one that you guys are aware of? But this is said to be a 16-year-old woman with syncope during field hockey. So we can talk about the ECG, but you know, this is not an asymptomatic athlete, so that's we're in a completely different frame of mind, I guess, panel. So how would Dr. Thompson, what would your thinking be here?
So I would think this would be an abnormal ECG, and I would start with an echo. First, I'd start with the history of the syncope. I mean, was she actually running when she passed out, or had she been running, stopped, lost the muscle pump, returning blood to the system, hot day, all that sort of stuff. So, you know, it always does start with the history and what prompted the visit. Syncope prompted the visit. What sort of syncope? What was it like prior episodes? But this is clearly an abnormal ECG.
Dr. Thompson, I thought you were going to mention athlete swoon.
So I'm big on athlete swoon. So let me tell you what athlete swoon is. This is the 16-year-old girl who wins all the dual meets. Got a very pushy father. When she competes in the national meet or the county championship, and if she isn't winning, she collapses about 100 yards from the finish line in view, is not totally out, but, you know, kind of not responsive. So I think and I believe this. I've seen a lot of athletes who have this sort of, I don't want to sound sexist, it tends to be female, it tends to be with a very pushy family, happens less frequently in men, but I see it all the time. And they usually, it's easy to make the diagnosis because they come with every study under the sun, sometimes electrophysiological studies as well. And everybody can't figure out what's going on. Well, you know what? It's easier to have a medical reason to fail than to just be not good enough. It's hard for people to be not good enough.
The ECG, the T-wave inversions, to me, until proven otherwise, smells of either a form of hypertrophic cardiomyopathy, so I definitely would want to work that up. And as Dr. Thompson said, thorough history about the syncope.
Yeah, HCM would be concerning here. You don't have the cal here to know what the voltage is, but particularly with the deep symmetrical T-wave inversions, you'd worry about an apical Yamaguchi type. Used to be called Yamaguchi, now it's apical hypertrophic cardiomyopathy. And with syncope during field hockey playing, as best we know, high probability that this is going to turn out to be an abnormal EKG in a symptomatic individual.
Example that we pulled from medical journals, a case report from one of the medical journals, and there was a case of apical hypertrophic cardiomyopathy that was confirmed on MRI with the imaging study there. So that was a nice example to show the group.
So this was apical HCM.
Apical HCM.
Thanks, Sid.
Yeah.
Any other comments or discussion on this case? We're going to manage that just like any other HCM, Dr. Estes or Chung or?
Well, we will, but we probably shouldn't, okay? So what you do with an individual like this, beyond the history of physical EKG and MRI, is get a stress test, look for blood pressure drop, get a Holter, look for non-sustained VT, look for family's history of sudden cardiac death, and actually quantitate the gadolinium. And then you're left in a hypertroph with syncope, a single risk factor. If they have over 3 centimeters, if there's a family history of sudden death, if they've got non-sustained VT, those are major risk factors in the US. One alone is sufficient to place an ICD. If they have drop with blood pressure, you can mitigate that because it's the least predictive with the gadolinium enhancement if it's over 30% and place an ICD. But by the old guidelines, hypertrophs with ICDs should not participate in athletics. By the new guidelines, they're actually given some liberties as to whether they participate if they're willing to accept the risk of participating. So, a further evaluation with syncope, with apical hypocofert cardiomyopathy is probably a more benign prognosis than with septal and outflow track, but we don't know that for sure. So again, lack of evidence, but I think prudence in this clinical situation would be risk stratify further with a Holter stress test, cardiac MRI, probably place an ICD, and I'd come down on the side of recommending athletic restriction, letting the patient participate if they, in the institution or organization that they participated in, accepted that risk.
So let me ask a question, and I really don't know the answer to this. I thought, Mark, that it was recurrent syncope, which was actually originally one of the 5 things rather than a single episode.
So it's unexplained syncope. Yeah. So if it's a typical vasovagal spell, you discount it, but a single episode of syncope is enough. Yeah, particularly with exercise, Paul.
This is just one case, but and more data is needed. But interestingly, the ST segments in this case report from Dresner that are not elevated in comparison to the
Good point.
20-year-old athlete from Duke who were we generally think was within normal. But,
Just one other point, and sometimes these electrocardiographic changes precede by years the morphologic changes on echo. And I've had a number of young athletes who show up these EKGs, echoes are completely normal, no symptoms. And the syncope and the hypertrophy occurs later. And that's something you need to be mindful about.
I think that's a good point. There are some cases in the literature that they thought apical HCM, the echo, even the MRI is normal, and then follow up. Of course, pattern evolves. Great point.
So the recurrent syncope issue related to HCM, though, so they've had multiple episodes of syncope coming in. Does that qualify pre-treatment as higher risk?
Yes.
Or just a single?
Single syncopal episode's no different than multiple syncopal episodes if it's unexplained. If it's the common faint, the vasovagal spell, you discount it. But particularly if it's exercise related or immediately after exercise, not stopping and cooling down and vasodilating as Paul's referred to, but a single syncopal episode is clearly sufficient, yeah.
So in long QT syndrome, is there a parallelism? Because in long QT, if you have somebody coming in non-treated who had syncope, we now discover they have long QT, you've explained their syncope and you treat.
With beta blockers.
With beta blockers,
Yeah.
we don't automatically put a device in. I think the treatment effects are much better.
Yeah, treatment effects are much
Right,
better.
That's my point.
Yeah, there's no beta blocker, calcium channel blocker,
Exactly.
amiodarone. As you guys know, none of you elected to put the patient on beta blocker, amiodarone, or calcium channel blocker when he'd had syncope with hypertrophic cardiomyopathy. So the only intervention that we know improves outcomes is the ICD. Yeah.
Okay, next electrocardiogram. I think we're getting behind in our sports cardiology clinic. We've got a line of patients out the door. A great discussion. So here's another challenge for us. Anyone want to bite on this?
Yeah, this one's not asymptomatic. That's incorrect. I apologize. This is a patient who's had syncope. Unclear if it was dehydration related, but has had syncopal history.
So a syncope, but not a definite arrhythmic kind of syncope. Is that right, Dr. Sun?
Yeah, this is playing soccer out in the summer. This EKG was sent to me, not necessarily, I did not see the patient, but this was sent to me with that story in the summertime, feeling poorly and while playing soccer and passed out.
So was syncope related to exercise, was it?
Related to exercise,
Yeah.
was very clearly what they were trying to write off as sort of a hot day, very, very sort of, North Carolina summer, 100 degrees humid.
Don't want to comment on the EKG, but the number of people I see who have a history of passing out from dehydration, who subsequently die in malpractice cases or whatever, is remarkable. Be very careful about making that diagnosis. You have to be in a race or being pushed in the Marines or something. Very hard for people to get heat stroke just training. You have to be crazed in some way to push yourself that hard.
Dr. Olson's going to be covering
Does
that
that
topic
include-
later today. I think it's an important one. Yeah.
Well, does that include running the Boston Marathon when it's 104 degrees at the start? Is that crazy?
That's when all the great ones run it, right, Bill? Except we finish a little differently.
Salim, this patient's a little older than your practice, but what do you think of the electrocardiogram?
Well, I'm not super impressed. There's a little bit of T-wave flattening in the inferior leads. There's a little bit of terminal QRS stuff laterally. Can't quite see anteriorly. I'd be suspicious, but the history throws me. That's an immediate red flag for me, no matter
So
what.
asymptomatic patient, you might pass this, but it's a different patient.
Younger, asymptomatic, yeah, I'd probably let it go.
Fill us in now, can you?
Yeah, does anyone else have any comments on the ECG, or is it pretty normal?
So the axis for this age is unusual, and I agree. There's something terminal that looks funny. So you're concerned about right ventricular stuff, and want to make sure you don't have any sort of either pulmonary artery lesion or something else in the right ventricle.
Yeah, so Paul, I agree. The right axis deviation in a 32-year-old male is unusual, and it is quite strikingly right axis deviation. And also, as Paul said, the terminal portion of the QRS looks a little bit wide, which is
So I'm pointing to what you're talking about there, Mark.
But I'm more interested in V5, V4, V5, V6.
Yeah.
That little thing in the end, what I call a stutter step.
Yeah, so it's not the width of the QRS is a really pretty reasonable marker of some type of underlying cardiac pathology. Now, this isn't going to show up in the guidelines, but sometimes there's just a gestalt, an instinct, an intuitive sense that there's more going on. It's made easy here because the patient's symptomatic, so you have to do further evaluation, which would include an echo. But if it really were truly asymptomatic, I don't think that this would fit any of the criteria for abnormal, including the right axis deviation if it's an athlete. But was it an athlete?
Not a competitive athlete, just recreational.
Yeah, so I think
Recreational athlete.
there's enough here with that right axis deviation, the terminal forces, as Paul pointed out, to give me that little uncomfortable feeling that something more needs to be done.
I would just add, this is a very common scenario in my clinic, and I think the ECG is gray, and I would end up doing some expensive workup probably.
Yeah, so the reason why this ECG was sent to me was because of that QRS abnormality in the terminal portion of the QRS. and the concern was for early repolarization syndrome. So as you can see, there's a big difference in how this is called early repolarization versus what we saw on the first EKG, which is a huge upsloping. And in fact, the way that early repolarization syndrome are, is what some of us have tried to change potentially to J-wave syndrome, is to really look at that terminal portion of the QRS. And the initial papers from Hasegawa looked at notching or a slurring pattern in that terminal portion of the QRS. So you can see in V5, V6, in V4 it's actually probably clearer, that slight notch that you see defined as either 1 millimeter or greater. The higher risk groups, usually 2 millimeters are larger. And then in the inferior leads, you have more of a slurring pattern in 2-3 in AVF. And that is, again, two distinct patterns that were both described by Hasegawa and his group, and then subsequently published on through the Finnish group as well. The pattern on this looks very different, though, when you talk about upsloping ST segments, flat ST segments, and descending ST segments. Typically, when we think about these, or when we look at a lot of these, the descending ST segment, and this was, again, out of the Finnish group, looking at 100 milliseconds from the J point to define that ST segment, whether it's flat, upsloping, or descending. The flat or descending ST segments are actually thought to be a more malignant form. Now, granted, that more malignant form is still on the order of tenths or hundreds of a percentile in terms of conferring risk of sudden death. So even if you found something like this, without a very, very clear history, it is also very difficult to know what you do with somebody with a quote-unquote more malignant pattern of early repolarization or J-wave abnormality.
So, do patients with true early repolarization have a higher frequency of sudden death with exertion? And does restriction from exertion in any way impact on the sudden death?
It's a great question. So it's interesting, and one of the ways that I sometimes, when I get referred these, I try to help differentiate the sort of more benign or is to actually exercise them. And there's some literature to show that exercising them will have either a more dynamic pattern or a fixed pattern, and that can help you potentially differentiate if it's more of a repolarization pattern or what some of us believe is a potential depolarization pattern similar to Brugada. And I think, again, that's why we want to sort of get away from the early repolarization name. As you can see, there's some hump, there's some notch at the end of that QRS complex. So whether that is a depolarization abnormality or a repolarization abnormality, I don't know if any of us can say, but there's certainly some gene mutations and some data from Charlie and Celovich and so forth that may suggest that this is similar to Brugada, but instead of Brugada being in the RV outflow tract, this may be in other parts of the heart, and mechanisms of scar and focal slow conduction zones can give you this type of pattern. So, I mean, similar to Brugada,
So with Brugada, so you don't restrict them from athletics.
You don't restrict them from athletics, agreed, but there is some in Brugada literature showing that exercise, and I think Dr. Thompson actually, you might have commented this or wrote about this, in that exercising can also help you sometimes differentiate between Brugada and right bundle branch patterns, because the Brugada pattern may actually accentuate post-exercise, whereas right bundles or so forth may not.
But I guess
What about the heat sensitivity of some of the mutations and exercise? Isn't that worry at all?
so certainly with hyperthermia or with any kind of fever, the Brugadas have a higher incidence of VF, usually in infancy. I don't know if that applies to the early repols. I mean, most of the early repols that I know of, have been involved with, have their sudden death either nocturnally or at rest, but not exercise related. And I don't think that the current guidelines call for athletic restriction of early repols.
No, I think the early repolarization, quote unquote, early repolarization syndrome is just the incidence is so small that I don't think you can make any recommendation of really anything, to be honest. I think it's an association at this point as opposed to a definition of the syndrome. This patient ended up getting echo and exercise tests and an EP study and was completely negative for everything. And even though he has a concerning history with a potentially concerning pattern, there was no further treatment done.
So you let him keep playing pickup basketball or whatever he was doing now?
Yes. This was I actually was consulting with a colleague here, but yes, that was the recommendation, the group recommendation.
Yeah, I just want to say the age here doesn't matter for me, for my world. So whether it's the 20-year-old or a 15-year-old or a 9-year-old, exertional faceplant syncope is full bore red flag, hard stop. You do not do any exercise until you see me, and would likely go down the path of catheterization plus EP study to make sure that there's nothing there.
So to follow up on the Brugada comment, we did a review article on Brugada and cardiac death during exercise, and there are two issues of concern. One is that it looked like the Brugada pattern became more common after exercise. In other words, it could help bring it out, probably when there's reinstitution of vagal tone. And the other thing is that it seemed like a lot of the events that happened in Brugada after exercise, and I want to say this cautiously, seemed to be post-exercise as well, when you have a reinitiation of that vagal tone. We tend to think of Brugada as, subject to night of stuff with this high vagal tone. There are 25% of the events supposedly are associated with exercise, but it's not been clear from those studies whether they're during exercise or immediate after exercise. We thought they were kind of after exercise. And then there's one other thing about Brugada. We increase vagal tone when we exercise train people. And I don't think we know what that means necessarily. And one of the themes that we've been interested in lately is that there may be some patient groups that actually could get worse with exercise training, that you could make them worse because of their underlying genetic defects. I'm sorry, I didn't talk about it.
Okay, excellent.